Okay, let's spend some time talking about brain pathology. So just in terms of an overview, we're going to be talking about trauma, stroke, infection, and tumors. Most of our time is going to be spent on stroke. So for a trauma overview, we can have subarachnoid hemorrhages, which are caused by like a blow to the head. Acute subdural hematomas, this is bleeding between the dura mater layers. Chronic subdural hematoma, so this is like a more long-term kind of bleeding between the dural layers. Epidural hematoma. Diffuse axonal injury, we'll look more at that. Those are related sometimes with motor vehicle crashes. Cerebral contusion, same thing. And then intraventricular hemorrhage, so bleeding within the ventricles. Approximately 45% of the trauma that we see to the head is from motor vehicle crashes, 26% from falls, 17% from assaults. Other causes are going to be sports injuries. 2/3 of the patients are less than 30 years of age, and men are twice as likely as women to be injured. So, typically when we do a routine head CT, we're looking at both like soft tissue and bone windows. So we're using the bone windows primarily to evaluate for fracture. And there can be linear fractures where the bones kind of match and then depressed, like from blunt trauma or like a blow to the skull. Sometimes we could have like depressed fractures. Sorry, there's a typo there. Get rid of an S. Most clinically significant is if the paranasal sinus or the skull base is involved. That'd be pretty heavy-duty trauma there. And fractures need to be distinguished from like sutures and venous channels. So we spend a lot of times talking about different sinuses and stuff like that on the anatomy, and that's one of the reasons why. So here's a skull fracture indicated by the red lines of the right parietal bone. Again, note the window level is this may not be evident on a soft tissue window level. So acute subdural hematomas can be related to like what they call acceleration or deceleration or rotational forces, and it's going to tear veins within the dura mater. And the blood collects in the space between the arachnoid mater and the dura mater. The hematoma on CT has some kind of telltale characteristics. It's going to be crescent shaped. It's going to be hyperdense, which we talked about. It's going to show up very white on the images. And it may contain like a hypodense foci due to like serum or CSF or active bleeding. And it does not cross the dural reflection. So it doesn't get past the areas where the dura mater kind of stops. So here we see that kind of telltale crescent shape, a high density on the patient's right side, and it's not crossing over the dural reflections, but it's shifted the midline across the septum due to like a mass effect. So it's just pushing the brain over to the patient's left side. Here's one with a hypodense region within the high density area of the hematoma, and this probably indicates some active bleeding, so a burst blood vessel there. Again, we have significant midline shift, so the ventricles are pressed together, and one of the reasons it's so critical for us to know our sectional anatomy well is so that we can know when things are not right. So with brain, fortunately, typically things look pretty symmetrical, and this image looks asymmetrical. So that's one of the first things that we would note is just how asymmetrical this image looks. So subacute subdural hematoma. These can be difficult to visualize on CT, so these are the patients that we might miss it on CT, but then it's apparent in MRI. because as the hemorrhage is bleeding, it's also being reabsorbed. So it becomes isodense, or it becomes basically the same attenuation value as gray matter. Nevertheless, we can suspect it if we identify that midline shift without any obvious mass, like a cancer. So at times with these, we may give contrast because then we would be able to see the interface between the hematoma and the adjacent brain. Or the patient may be referred to MRI. So here we see a compressed lateral ventricle and effaced sulci on this side over here, and white matter buckling and a thick cortical mantle. Nevertheless, I mean, it hasn't produced midline shift, but we see that the sulcus have buckled and moved out of its way. So a chronic subdural hematoma. Chronic SDH becomes low density as the hemorrhage is further reabsorbed. So it's going to go from high density to become isodense, and then low density will actually start to turn black. And it's uniformly low density, but it may become loculated, like it may have like little globes to it. And then rebleeding can occur. So there may be like a black area and then a white area where there's near where the active bleeding is occurring. So here's a chronic bleed here. So this has been going on for several days. And the primary thing to note is it still is that crescent shape. It hasn't passed over the reflective area of the dura mater, and it has a low attenuation due to reabsorption of the hemorrhaging blood. Here's the loculation kind of thing. So we see little compartments to it. There's hypodense areas, in here, and then hyperdense areas like this, which may indicate a continued kind of small active bleeds. So septations and loculations that can occur over time, just due to the way the folds of the arachnoid and dura mater. So an epidural hematoma, and these are normally associated with some kind of skull fracture. So if we identify one of these, we're going to be looking at the bone windows as well to see if there's a fracture nearby. And it's going to occur with an impact fracture to the calvarium. So the fractured bone lacerates the dura artery or venous sinus, and the blood from the ruptured vessel collects between the skull and the dura mater. So in terms of appearance, it's going to form a hypodense biconvex mass, and it's usually uniformly high density, so it's going to be white on our images, but it could also contain like a hypodense foci due to active bleeding. And then an epidural hematoma is extradural if it can cross the dural reflections, so unlike a subdural hematoma. However, they don't normally cross the suture lines. Okay. So here we see both hypodense and hyperdense area, and this red arrow here is indicating a fracture line. It'd be helpful to evaluate this kind of injury on both bone and soft tissue windows to be able to evaluate how the fracture has come in here, the rupture, the bleed, and the extent. We would need to measure this. So biconvex means that it's got this area and then it's got that area. And then a deep parietal skull fracture on the patient's right side. So diffuse axonal injuries. This is like a shearing injury, and 50% of all primary intraaxial injuries are diffuse axonal injuries. So we're talking about acceleration, deceleration, rotational forces that cause portions of the brain with different densities to move in relation to each other, resulting in a deformation or tearing of the axons. So like a severe whiplash kind of injury. And we're going to see ill-defined areas of high density or hemorrhage in kind of like characteristic locations, like areas between those axons of the brain. So here's an ill-defined areas of high density or hemorrhage in characteristic location, And one of the things we're seeing is within the internal capsule, right? Bleeding within the internal capsule. So between the axons of those lobes of the brain and the internal capsule, and so a hemorrhage within the thalamus. Here's a hemorrhage within the corpus callosum, right? So again, between different areas of the brain. Cerebral contusion. So this is one of the more common primary intraaxial injuries, and it can occur when the brain impacts an osseous ridge or dural fold. And what we're looking for is an ill-defined hypodense area with a foci of hemorrhage, and after a day or two, that hemorrhagic presence is going to coalesce and kind of round out. So here we see multiple foci, right? And this is just above the optic shelf of the frontal bone, right? So we can actually see a portion of the optic cavity, the patient's right optic cavity here, probably the superior optic nerve, a superior rectus muscle there, I'm sorry. The patient is clearly rotated in the scanner because we can see mastoid air cells on the patient's right side but not on the patient's left. Nevertheless, this is perhaps the best the tech could do given the considerations, but for our purposes what we're looking at are these different little areas of high density where we've almost got like a bruise or laceration injury caused to the brain because the cerebral matter has impacted the left frontal bone. So intraventricular hemorrhage. So again, associated with trauma like a car accident, and we see one here in the lateral horn. And then also over here, related. So this could be the kind of thing where there's a side impact injury, and the patient was hit from the side. The brain kind of sloshed around, and we now have bleeding within the ventricles as well as on perhaps the side of impact. Okay, so let's take a step back from trauma and now talk about stroke. Okay, ischemic strokes are going to be the most common, and they can be thrombic, so there's a blood clot within a brain artery. Embolic, so it's a clot is traveling around in the bloodstream that forms somewhere else, like in the legs or something, and it is freed up and it's pumped out through the heart up the carotid arteries and then forms a blockage. And then lacunar, which is like if it winds up in these little small arteries. And then hemorrhagic stroke is only 20% of what we see, and these could be like subarachnoid or arteriovenous malformations. There's actual malformation that just congenital to the patient. All right, so stroke is the clinical term for a sudden focal neurological deficit, and we know kind of the telltale signs: numbness, confusion, weakness, like typically on a single side. And they're classified as either hemorrhagic or ischemic, as we discussed, with lacunar being a small subset. And hemorrhagic strokes account for 16% of all strokes. And ischemic stroke is caused by a blockage of blood flow to a major cerebral blood vessel, usually due to a blood clot. Okay? So we're moving from outside the brain, like in the dural matter, the dural sac, or within the ventricles, to areas within the brain, now within the cerebrum. So they can be caused by thrombosis, an embolism of thrombosis, hypoperfusion, so not enough blood perfusing through the brain, and then infarctions within these little tiny arteries. So, sorry, apologies for this stroke, but this slide. But what it's basically pointing out is that this middle cerebral artery, the basilar artery right here, is showing up hyperdense on the images. This is a non-contrasted study, and we can compare that with a normal left middle cerebral artery. Yeah. So something over here or over here. All right. So basilar thrombosis, the blood clot in the basilar artery. We have a dense basilar artery here. The arrow is indicating it. And again, we're going to compare this to a normal internal carotid artery. So very dense right here, not very dense right here. Lentiform nucleus obscuration, right? So hypodensity in the left hemisphere. It's involving the caudate nucleus and the lentiform nucleus. These can be a little bit more difficult to pick out. But if we look at the caudate nucleus over here versus over here, we have a nice definition of densities between this and this area. Over here we don't see that, it just kind of looks more like a blob. So it is hypodense. Okay, so here's some diffuse hypodensity and sulcal effacement. So we over here we have these nice sulcuses that we can see real clearly. Over here I'm not seeing that. And it's diffusely hypodense, so it's darkening this whole area of the brain, right? We're not seeing the sulcuses. So something is impairing blood circulation to that area. So here's a CT of a subacute infarction. And this is something where we wait like a day or two or three, and we see an increasing mass effect and a wedge-shaped low density, and then hemorrhagic transformation. Okay. Incidentally, this is not blood here. I believe this is just a calcification inside the aorta, or inside the lateral ventricle, which can be normal. Hemorrhagic stroke. Hemorrhagic strokes account for about 20% of all strokes, so 16 to 20%. If it's within the cerebral, so intracerebral hemorrhage is the most common, and then we can also have these subarachnoids due to a rupture of a cerebral aneurysm. That's going to be a little less common. So subarachnoid hemorrhage, due to a small injury of small arteries or veins on the surface of the brain. So on the surface of the brain, not the dura mater. Ruptured vessel bleeds into the space between the pia and arachnoid matter. When traumatic, a subarachnoid hemorrhage occurs most commonly over the cerebral convexities or adjacent to otherwise injured brain. So it's going to be kind of in the area where they get of impact. And then in the absence of significant trauma, the most common cause is the rupture of a cerebral aneurysm. So on CT, a subarachnoid hemorrhage appears as a focal high density in the sulci and fissures near the linear hypodensity. So all these little twists and turns. If we were able to scroll through these images all through these little areas, we would see little fingers of white. So in the presence of trauma, the most common cause of a subarachnoid hemorrhage is a ruptured cerebral aneurysm. So it's in the absence of trauma. And this is going to tend to occur at a branch point of intracranial vessels, which kind of follows with what we know about how blood clots work. They come to a branch, and the stuff narrows, it'll go to the wider side and clot off, and then all of a sudden you have bleeding that now spread to pressure has gone to peripheral vessels, and now we've got bleeding kind of throughout. So this ruptured, and now it's bleeding into this area here. So here's this arteriovenous malformation. So we may or may not be able to see this on a CT scan. A lot of times we're going to have to administer contrast, which is what has happened in this. And after contrast administration, we're going to be able to see this serpentine enhancing structure. I have actually seen this once in a patient. It was very strange looking. It was not completely clear prior to contrast, but then after we saw this kind of coiled serpent appearance. Here's a hemorrhage of the cerebellum, right? So one of the things that we've noticed kind of throughout these images is that they are enhancing without contrast for the most part, except for the malformation, and the edges are kind of ragged in appearance, and it's just something to keep in the back of our mind as we're comparing different kinds of pathology. Intracerebral hemorrhage. The most common causes are hypertensive, angiopathy of the amyloid, ruptured vascular malformation, stuff related to poor coagulation. We can actually hemorrhage into a tumor, or tumors could impinge on a blood vessel and cause a hemorrhage. A venous infarction, or drug abuse. People who use drugs a lot can have a intracerebral hemorrhage. So here we are within the cerebrum. This is a hemorrhage within the thalamus, and it's extending. It's poured out into the lateral ventricle. So hypertensive. This is commonly due to vasculopathy involving deep penetrating arteries of the brain. Okay, and what we're gonna be looking for is high density hemorrhage in the region of the basal ganglia, and then the blood may extend into the ventricular system. These people are not happy campers, but hypotensive. So hypertensive. So the patient's blood pressure shot up too much, and we burst an artery, and now it's bleeding out within the cerebrum. Okay. Again, apologize for this slide. When they imported it in, they just kind of made these little hiccups. So related to poor coagulation, coagulopathy related to intracerebral hemorrhage. On imaging, this is going to have a heterogeneous appearance due to incompletely clotted blood. So we see this nice demarcation line here between the part that is forming a clot and the part that is not clotting. So this is probably an area of active bleed, and then over here we have that hyperdense area. Okay. So in terms of advantages and disadvantages of CT for evaluating for stroke and for trauma, a lot of places have it. It's readily available. It's very, very quick. And so, as we mentioned earlier, if we're dealing with an institution that has a stroke protocol, generally we need to get the patient's exam performed and read within 30 minutes of when they call that stroke protocol. So it's very, very rapid. And it allows for an easy exclusion of hemorrhage or trauma, and it allows for assessment of parenchymal damage. But there's some disadvantages. We have a hard time determining if it's an old versus a new infarct. There's not functional information. So for functional information, that's really, really difficult for us to evaluate that. We have perfusion scans, but those aren't typically a routine for this kind of stuff. And then we have a limited evaluation of the vertebrobasilar system. So it's very difficult due to beam hardening to see through the base of the skull and evaluate where, like for instance, the carotid artery enters exactly. And a lot of times it's often obscured by anatomy and beam hardening. And then of course radiation is a disadvantage. In terms of sensitivity though, I'll move the slide up. CT is 58% sensitive for infarction within the 24 hours. MRI is like 82% sensitive. So if the patient is imaged greater than 24 hours after the event, typically both CT and MRI are greater than 90% sensitive. So if we don't catch it in CT, a lot of times they refer them to MRI. Now let's move on and consider infection. So if we're suspecting meningitis on a patient, we will probably be doing this prior to the lumbar puncture. So our imaging is not usually performed to diagnose meningitis, but because the CT images are probably going to be normal despite presence of the disease. So nevertheless, we may do a CT head prior to the lumbar puncture, just to make sure that there's not something else going on. So we also on the CT, we're going to be able to evaluate for hydrocephalus. Nevertheless, these other things may not be as clear. So ventriculitis, epididymitis, subdural effusion, subdural empyema, cerebritis, abscess. We may be able to see an abscess. Vasospasms, of course, we're not going to be able to see that. Arterial infarcts, possibly. Venous thrombosis, possibly. So it's kind of a mixed bag. All right, so here's a clear case of hydrocephalus. We just see enlarged ventricles in the coracoid plexus here within the ventricles, pumping out all that CSF, but it doesn't have any place to go because perhaps an infectious process or something else has backed up the CSF, and it's now just creating a tremendous amount of pressure within the ventricles, and this is a common appearance of hydrocephalus. Ventriculitis, so post-contrast CT, we can notice a ring of enhancement here, almost like a tuberculosis on an x-ray. And we also see enhancement of the epididymal lining of the left lateral ventricle. So this nice helpful arrow here. And again, that's enhancing with contrast. Okay, well, let's talk a little bit about tumors. Intracranial tumors are generally present with a focal neurological deficit, seizure, or headache. So a lot of times these patients just present with a headache, but they have a history of lung cancer or some kind of metastatic disease. Typically they may present as a well-defined circumscribed mass, but that's with contrast. And without contrast, we have a difficult time sometimes seeing these things. They might also may be irregular masses with necrosis and hemorrhage, so they can be necrotic centers to it, which is common for cancer, or we may, with contrast, actually be able to see like neovascular, where the tumor has actually created blood vessels to feed itself. So here's a glioblastoma multiforme. We have this ill-defined low density in the right frontal region of the brain here, and so that's prior to contrast, and then with contrast administration we see an extensive kind of patchy enhancement, and that again it crosses the corpus callosum, so we have extension into the patient's left cerebrum, and all of these whitish stuff around here is possibly neovasculature that the tumor has made to feed itself, and then the black stuff is probably necrotic. Okay, meningioma. So this is a common extraaxial neoplasm of the brain, and middle-aged women are most frequently affected. And 20% of meningiomas are calcified. So on CT, they're going to normally present as iso-intense to gray matter. But then when we administer contrast, we're going to see this nice enhancing blob here. So this is post-contrast demonstrating a broad-based enhancing extraaxial mass. Thank you.